Good afternoon. Thank you for inviting me to this very important meeting. So I may inform you that we sent 3 of FETP staffs to Sierra Leone under Guan. Gina Saman, who is now with the WHO headquarters, Theodora Banning, and Mas Dalina Pane. 3 tough ladies spent 1.5 months in Sierra Leone. They went back home safely. Of course, I will be talking about flexibility in pandemic planning, preparedness, response, and international health regulation implementation. It's 5-1 experience in Indonesia. 2 weeks after I've been appointed as a Director General of Disease Control, Ministry of Health Indonesia, I was facing 3 unusual events. Number 1 is imported wild polio virus, Nigeria, Yemen, Saudi Arabia, and then exploded in Cidahu, West Java. And then we did mopping up and sub-national immunization days. Not enough, the polio virus spreading throughout the country, to Sumatra, East Java. At that time, the Deputy Director General, Professor David Hammonds, came to Jakarta, met me. Nyoman, you must conduct national immunization days. Sub-national immunization days is not enough. At that time, I said to David Hammond, you are coming not on the right time. You are coming in the middle of fiscal year. No money. We have brain, we have muscle, we have system, but no money. Since polio eradication is a global commitment, please come with support. Then, actually, this imported polio virus came to Indonesia after the, what we call it, multi-dimensional crisis, of the government, and then all the infrastructures collapsed, and then coverage of immunization going down, etc., and then imported polio virus. After conducting 6 national immunization days in 2005, February 2006, we, Indonesia, became polio-free again. The second one is H5N1. First human case was reported during my time. At that time, I got a telephone call from one private hospital, big hospital, Siloam Gleneagles, from intensivist. He called me. We have a cluster of severe pneumonia, one family. So actually, this intensivist wanted to transfer these cases to hospital under my jurisdiction, infectious disease hospital. At that time, I'm epidemiologist. If only one severe pneumonia in one family, I'm not interested. But 3 at the same time, something wrong. And then we found this is the first human case of H5N1 reported. So most of you are epidemiologists. This is the course of typical propagated epidemic. If you draw the epidemic curve, it looks like the bell shape, It's very much how, like this or slope like that. It's very much depend on how our capacity to detect, to prevent, and to respond on the right time. So, and then if you are talking about pandemic and health security, globally it is recognized that pandemics can affect health security, of course, especially if late detection or notification and late or inappropriate response. That is why if we are talking about international health regulation, and we are talking also about the global health security agenda as the implementation of international health regulation, we need to strengthen our core capacities, what's so-called capacity to detect, capacity to prevent, and capacity to respond immediately. Impact of pandemic, of course, has been presented previous presentation, so I won't repeat it again. Pandemic, all countries worldwide are affected, but impact may vary both between and within countries. For example, Spanish flu in the past showed that mortality rates in Europe and North America were significantly lower than those in Asia, Sub-Sahara, and Latin America. Why the difference in mortality? Because a lot of determinants involved in this. Implication, of course, pandemic planning need to be tailored for each country's situation, specific countries. Of course, my talk would be about Indonesia. Indonesia is a developing country with 17,500 islands during low tide. During high tide, some with 250 million population. If we are talking about 30 years doubling time, in 30 years from now, Indonesian population will be 500 million with all the problems they are facing now. Dialects, yeah, and then we have 34 provinces, 514 districts. Like any other developing countries, of course, we are facing health challenges, TB, HIV, malaria. Of course, we are going to eliminate malaria in 2030. We are implementing decentralized system. It's not centralized like in the past. District mandated for disease control under authority of district elected official. Actually, the decentralization is supposed to be to bring the quality services close to the people. But in fact, it's not that easy because, the city mayor, governor, they're like the king, no? It is not easy to, what we call it, to control, to supervise. History of a pandemic in Indonesia. This is the history of pandemic in Indonesia, epidemic, 1957, 1969. Cases series from Indonesia were reported in 2 articles in 1958, 71. Limited knowledge about history and epidemiology of influenza in general population. Research studies and surveillance work 2000-2005 focus on assessing influenza disease burden. Talking about, this is one, okay. Talking about avian influenza, actually the outbreak was in the animals and the birds, 2003. Right after that, we collected blood specimen from those who close to taking care of the bird population. None of them were positive for H5N1. And by 2005, the first human case, like what I mentioned just now, was detected in an urban area on the outskirts of Jakarta. Yeah. And then the emergence of this disease in Indonesia quickly caught the attention of Minister of Health, government authorities, and of course the public. This is the distribution of bird flu in Indonesia. We have 15 provinces affected and 17 clusters. So it is a very, what we call it? Most of the clusters belong to the family, genetically susceptible, genetic susceptibility. Clusters is a close family member. This is the distribution of human bird flu cases in Indonesia. The case fatality rate is very high, I can say. 65 in 2005, and the average is above 80%. 8 out of 10 died. The case fatality rate is very high for Indonesian bird flu. So what is the Minister of Health and government's role in this case? Of course, prepare nation for pandemic, respond to H5N1 outbreaks. Indonesia had to prepare for a pandemic and respond to a disease epidemic at the same time. At that time, we, from WHO, the phases of a pandemic were 6, Phase 1, Phase 2, Phase 3, Phase 4, 5. Phase 6 is the pandemic itself. Now, they cut it down into 4. Of course, the role of MOH and government provide leadership and coordination among different sectors of the government and for the whole of society. Plan for effective risk communication is very important. We are facing epidemic of panic before, during, and after the pandemic. Actively collect, analyze, and disseminate data for making informed public health decisions about the pandemic or epidemic. Plan for and implement all available measures in an ethical manner to mitigate the impact of the pandemic. ensure continuity of healthcare provision during the pandemic. So we are talking about public health ethic and principle. So of course, WHO guidance on ethics and infection disease outbreak focus on the cross-cutting ethical issues that apply to outbreak generally. Of course, examine how this principle can be adapted to different epidemiological and social circumstances. Reasonable and effective means, proportionality, distributive justice, trust, and transparency. Of course, they are under good governance. If we are talking about good governance in Indonesia, we are talking about 3 pillars. Number 1 is a predictable framework of the law. Number 2, transparency. And number 3, of course, the accountability. One issue, equitable access to healthcare. Of course, in pandemic, how to allocate vaccine, antivirals, and hospital care. Should some population group have priority? At that time, we allocated 200 billion rupiah to purchase H5N1 vaccine from Baxter actually at that time. Should some population group have priority? Who should be given this vaccination in case? For example, should healthcare workers be prioritized to receive oseltamivir or a vaccine? It was not that easy to make a decision. How to allocate resources in advance and during the epidemic or during the pandemic, between pandemic influenza and the health sector. Of course, if we are talking ethics in pandemic planning, and an example, decision on WHO vaccine donation. At the time, I involved in small group discussion in Geneva, if this stockpile of vaccine, where should be placed. At the time, I proposed put it in Singapore because Singapore is reachable from all parts of the world. Donation was not accepted. We have to discuss with the parliament members. Utilization of oseltamivir for priority groups, since the initial countries affected by H1N1 pandemic 2009 had primarily mild infection. Indonesia still emphasized H5N1 cases for oseltamivir C. Lesson learned. Of course, high political commitment needed, whole of society involvement needed. Well, first, Mr. President at that time also involved in government department, agriculture, labor, education, defense, transport, trade, judiciary, private sector, civil society, and so on. Ethical consideration for response, community, family, and individual preparedness, consideration of existing resources as well as unmet resource need. So this is economic impact, selected infectious disease outbreak globally, how much, this impact, billion of US dollars. As attention grows in public health to the impact of emerging infectious diseases and the importance of international health security, public health practitioners are faced with a number of challenges. So if I go back to the definition of public health, the application of science and medical knowledge to the protection and improvement of the health of the group. Some definition also preventing disease and prolonging life, but I may define public health as there are two components of public health. One is a public policy, and then the other one is the public that we serve. If we are talking about public policy, if it is a bottom-up decision-making process that we use the evidence, epidemiology is an art and science on how to define it. The need of the people, defines by the evidence with the epidemiological calculation. This morning discussion was a very good discussion about how to prioritize. Epidemiology will give evidence how to prioritize. That is why in the human resource development field, epidemiology training program is one of the workforce development to give the opportunity for evidence-based decision-making process. Public health needs, the need to develop national capacity to detect, like just now, pressure to stockpile expensive treatment at a time when vaccine affordability for common childhood illness is under question in most of the countries. 24 media cycle, where media reports about 12 o'clock midnight, journalists call me, wake me up, So I'm happy now, retired from government service. So currently there are 5 major uses of term public health. Public policy and that public we serve equates the word public with government action. Number 2, the participation of organized community. Nothing you can do without participation of the community. Risk communication and public awareness is a very important one. It is easy to say, but it's not that easy to implement. No? Equivalent to non-personal health services, focuses on provision of certain preventive health services, particularly to vulnerable, high-risk group, like what mentioned this morning about the threshold, cut-off point, refers to organized response to public health problems that are common or life-threatening diseases. I quoted from our senior James Sepulveda from Mexico. Health managers have to look at certain opportunities in this crisis. They have to find out ways to have health share of the stimulus, because by doing so, they will not only help in getting rid of the crisis, but also minimizing the threat of emerging diseases and strengthening international health security. At that time, we used to strengthen our capacity. The referral hospital, 100 referral hospitals were equipped for isolation room, etc. Forward planning and budgeting is needed to address real need. This is useful for activities such building up lab, primary health care, isolation room with negative pressure, establishing schools of public health, recruiting health personnel in areas where the number of health personnel is inadequate, building up networking for information, improving environment. This is the epidemiology and health services and health policy cycle. I believe you are very familiar with this. Of course, we use this, the healthcare planning cycle. Of course, if you are talking about health and sustainable development, if you are talking about zoonotic diseases, this One Health principles, animal-human interface. Sometimes our the animal health, they are thinking and isolated way. So human beings are at the center of concern for sustainable development. They are entitled to a healthy and productive life in harmony and nature. So human beings, I repeat it again, human beings are at the center of concerns. If we are talking about, for example, like rabies, dog bite, man. Actually, who is responsible for dog? Since dog is economically, it's not like cattle like that. So animal health do not care about dog. So currently there are 5 major uses of term public health. Equates to public health is okay. So ready. Fact sheet for candidate diseases for control, elimination, and return has been discussed deeply this afternoon. Of course, disease condition, etc. I don't want to repeat it again, but at least principal challenges in the future to challenge elimination, eradication. So, learning from your Ebola, failure in early response to outbreak, of course. You see, this is, I will not repeat it again, but lesson learned from the past, how to improve. If you are talking about global health security agenda, Indonesia is now chairing the Troika this year. And then next week we will have the steering committee meeting in Bali. We have 11 action packages where the number 2 is zoonotic disease. We understand most of emerging infectious diseases, 70 to 80% caused by zoonotic diseases. And then for immunization, of course, national lab. If we are talking about detect, real-time surveillance, reporting, workforce development. So I'm taking care field epidemiology training program. And also I'm chairing the workforce, what's so called FEETP, Field Epidemiology Education and Training Program. Based on Global Health Security Agenda Action Packages, each country should have one epidemiologist over 200,000 population. For 250,000 million people, we need to have 1,250 something professional epidemiologists. But beyond that, we need to have also intermediate epidemiologists, worker bee epidemiologists. So we need about 22,000. That is why we are not talking about education, but we are talking about training program. So I'm sharing this workforce. We are developing a curriculum and module for epidemiology education. So this is One Health approach to deal with zoonotic diseases: identify, predict, prevent, response. That's all my presentation. Thank you for your kind attention.